Great. Good morning, everyone. Thank you all for getting up early and joining us. We are very excited to introduce today Dr. Andrea Knight. Dr. Knight is a pediatric rheumatologist at the Hospital for Sick Children or Sick Kids in Toronto, Canada. She's a senior associate scientist in the Neurosciences and Mental Health program at Sick Kids Research Institute and an associate professor of pediatrics at the University of Toronto School of Medicine. Dr. Knight received her medical doctorate from Columbia, and she's no stranger to Pennsylvania, completing both her pediatrics and rheumatology training at Children's Hospital of Philadelphia. She is the past chair of the lupus section for the Childhood Arthritis and Rheumatology Research Alliance, the current co-leader of the CARA Mental Health Work Group, and co-leader of the Cassie and Friends Youth Mental Health Working Group. She's also a member of the Canadian Rheumatology Association Research Committee, Scientific Advisory Board for the Lupus Research Alliance, and Medical Scientific Advisory Committee for the Lupus Foundation of America. She's co-chair of the Sick Kids Mental Health Strategy Research Implementation Team and a member of the advisory panel for the Sick Kids Precision Child Mental Health Initiative. She has been working tirelessly to expand our knowledge on, in particular, psychiatric and mental health of children with lupus. And we're excited to welcome her. She'll be talking to us about optimizing outcomes for children with childhood-onset lupus, a focus on brain health. So please join me in giving her a warm welcome to Pittsburgh.
Thank you for the warm welcome and kind introduction. I have no relevant disclosures. So for the presentation today, I have three main objectives. First, to describe the prevalence and risk factors for neuropsychiatric conditions in children with systemic lupus. Second, to discuss the impact on outcomes of neuropsychiatric conditions for this population. And third, and probably most importantly, to discuss opportunities to improve brain health for this population. So some of you might be familiar with lupus, others maybe not so familiar. So I thought I'd start with just a little bit of a primer on what is lupus. This is a chronic autoimmune disease, which we see in pediatric rheumatology, perhaps not one of our most common conditions, but definitely something that we see and that I personally find very fascinating. And I hope that you will also be excited about thinking about this condition. So it is not exclusive to children. There is a childhood onset form, however, in addition to the adult onset form, typically affects adolescents. It's not that common. Incidence is about 1 in 100,000 children. It is classically described as autoantibody positive. So this is like an ANA positive, anti-nuclear antibody positive type disease, although there are many different types of antibodies that can be associated. And it is comprised of multi-organ inflammation. So many different organs can be involved in lupus, which is what it makes it so fascinating, but also very challenging. Lupus doesn't look the same in every individual. So it can involve kidneys and skin in some people, for example. It can include blood and brain in other people, for example. One of the most challenging and severe organs involved in lupus are the kidneys. So you might have heard of lupus nephritis, but the other organ that I'm going to really focus on is the brain. So central nervous system, neuropsychiatric lupus, which we'll talk more about. It's important to recognize also that lupus does not have a cure. So this is a chronic condition which we treat with immunosuppression, which is long-term and often intense, but we don't have a cure as of yet. So this can be a real burden for the children and their caregivers. The other thing I want to impress upon you is that this is not a benign disease. There can be severe organ damage that is life-threatening. I wanted to draw your attention to a study that was done in 2018 looking at death certificates in the US amongst females in general. And what they found was that amongst young females, so for those 15 to 24 years age, lupus was the 7th leading cause of death, which is surprising, right? For a disease that's not that common, 1 in 100,000 people. You have lupus on par with diabetes, and that's behind other more common things like malignancies, but still it makes it in the top 7. Now, when they looked at Black and Hispanic females, lupus became the 5th leading cause of death. So it is known that lupus has a disproportionate incidence in marginalized or minority groups, racial and ethnic patients. About 2/3 of the patients are from these groups for reasons that we don't fully understand. And then it also disproportionately affects females. So this is very striking. More than 85% of our patients with lupus are females. When you have this, you think of not that males aren't affected, but typically affecting adolescent females, typical onset 12 to 13 years of age, and also affecting racial and ethnic minority groups very prominently. This is important to think about when we think about outcomes. So something that, I think is important to emphasize, particularly in the current climate, are that there are disparities in this population. So we see racial, ethnic, social, environmental factors influencing care and outcomes for this population. There's a lot of literature talking about disparities in renal outcomes. So who ends up with end-stage renal disease, who ends up with dialysis, who ends up needing transplant. Cardiovascular mortality is also different, as well as all-cause mortality, even hospitalization rates. So this is something that I want you to keep in mind as I talk about this topic. So let's bring sort of a fictitious case in the mind to think about, okay, this girl, she's 15, she has a new diagnosis of lupus. As I said, lupus looks different in different people, but for her, she has clinical features of arthritis. So she's got joint involvement. She has fatigue, very common. She has a facial rash. Many of you might have read in the textbooks, a butterfly rash, which is very apparent. She also has hair loss, very distressing. She has low blood count. She's anemic. She has thrombocytopenia. She also has thrombosis. And she has nephritis. So that's like a long list of stuff, but this is absolutely what we see in our lupus patients. So it's complicated. She gets treatment. She gets prednisone. She gets immunosuppressant called mycophenolate mofetil or Celsap. She also gets something called hydroxychloroquine. This is sort of base treatment for someone of this severity, but there's usually other adjunctive stuff that it has to be in place for them to be treated appropriately. Notably, she's seeing many different specialists, not just rheumatology, but nephrology, hematology, dermatology, ophthalmology. And over the course of her disease, she might see more and more specialists as things evolve. So she presents, though, in addition, with low mood. She has some suicidal ideation. She feels foggy. She complains of like this brain fog, not quite thinking the way that she normally would. And she also has some social challenges. There's some financial hardship in the family, and the caregiver is very, very stressed and has a lot of sort of mental health challenges of their own. So this is not uncommon for the type of clinical picture that we see for our patients. So we'll leave this and we'll think about a little bit more. I'll talk to you a little bit more about neuropsychiatric conditions and how we think about this in lupus. So the American College of Rheumatology actually defines 19 different syndromes in these case definitions. They're divided into central nervous system and peripheral nervous system, and you can see a long list there. So what I want you to get from this list is that not only do we have a heterogeneous disease of lupus affecting different organs, but within lupus, we have a heterogeneous set of neuropsychiatric symptoms. So it adds to the complexity in this population. So if you look at different populations, you'll get estimates ranging from 20 to 70% of kids with lupus having central nervous system disease in particular. The reason for that wide range is because we don't do a good job at diagnosis, and you'll see that throughout the presentation, reasons why. 40% of these patients will present with their CNS symptoms at presentation. 70% will develop them within the first year. So this is something that's happening towards the onset of the disease. Also complicated by the fact that the patients with CNS lupus, for example, can have overlapping manifestations. So you don't just have necessarily headache, or you don't necessarily just have cognitive dysfunction. You can have psychosis and cognitive dysfunction and mood disorder all together. So this makes it very complex and complicated trying to sort out. But above all, this requires the most intensive types of treatments that we have, such as steroids and chemotherapy. So it's not a light diagnosis when we are diagnosing somebody with neuropsychiatric lupus on top of sort of regular lupus, if you will. So I mentioned the prevalence can be wide-ranging. Luckily, there's a recent meta-analysis that took data from 9 papers characterizing just over 1,400 patients, and basically using definitions according to the American College of Rheumatology. They found that about a quarter of the patients had neuropsychiatric diagnosis, representing 800 and so neuropsychiatric events and about 2.5 events per patient. So I sort of put in this purple box, the CNS manifestations. So you can see they come out at the top, with headache being the most common, although it's a little questionable in terms of how people are defining headache. But of note, seizure disorders are quite prevalent, as are cognitive dysfunction and mood disorder, as well as psychosis. Cerebral vascular disease is stroke, and acute confusional state we see pretty frequently as well. You might say, okay, well, most of this stuff should be readily apparent, right? If somebody's psychotic, okay. If somebody has stroke, okay. We have a lot of trouble, though, with cognitive dysfunction and mood disorder in terms of attributing it or saying that this is due to lupus and not other causes. The other thing to keep in mind is that this is an inflammatory disease that can cause an inflammatory insult on the brain. So as I mentioned, that this is a autoantibody classically disease. However, we don't fully understand the mechanisms, and there can be other things that are happening regarding inflammation. But this is all happening as the brain is developing. So this is a diagram from a review that we did that shows in the orange the onset of different neuropsychiatric symptoms, again, in adolescence, usually around like 12 to 18 years of age. But if you look down at the bottom, WM is white matter, GM is gray matter, and you have cerebellar volumes. This is just characterizing that there's changes happening during this developmental time. So not only do you have a chronic disease onset, but you have inflammation happening systemically that may be affecting the brain. So very important to keep this in mind. So what are the mechanisms of brain inflammation that could be acting? So I mentioned the antibody-mediated injury in the bottom left could be happening. There's also disruption of the blood-brain barrier. There's the lymphatic system, which is being more and more characterized as a contributor. There's disruption of the meningeal barrier as well as the blood CSF barrier. All of these things can contribute to neuroinflammation, brain atrophy, and neuropsychiatric symptoms. We don't fully understand this. The brain is kind of hard to study, right? It's isolated. We don't really do brain biopsies so much. And we don't really have the ability to study this with direct tissue. However, it's up and coming that people are using things like organoids and different types of mechanisms and methodologies to understand this more. But for now, we have a lot of clinical challenges. So as I mentioned, we have heterogeneous syndromes. The mechanisms aren't well understood. We have difficulty with attribution to lupus, what's due to lupus, what's due to other things. As a result of all of these things, we have limited diagnostics. So we typically use conventional MRI, brain MRI, CSF analysis, but these things maybe are helpful about 50% of the time. If you look at the studies, sometimes we can see what we call non-specific hyperintensities on a brain MRI. A lot of times, though, they don't correlate to actually what's happening clinically. So we do have very limited diagnostics, and we also have limited treatments. We're actually still using treatments that we've been using for pretty much 50 to 60 years. So we have a lot of work to do. So just as an example, and again, I'm going to focus more on mood disorders and cognition for the rest of this talk. Mood disorders in lupus could be due to lupus on the left, but you can have all these other things contributing, such as medication effects and adjustment reactions to illness. These can all contribute to the mood disorders that we see in our patients, and even cognitive dysfunction. There are many other things that can be contributing as well, besides the neuropsychiatric recognized syndrome. So while cognitive dysfunction has been associated with lupus disease measures, it's also associated with things like pain and sleep disturbance, fatigue and depression that may or may not be due to lupus itself. So overall, this diagram tries to summarize a little bit of what I've been saying. So you have a teen brain. Prior to lupus, it's already under construction. It's already undergoing development. But you have all of these different things that could be contributing to brain health, such as inflammation, treatment effects. We use a lot of steroids. I'm not going to get into that in detail, but we know that steroids can affect the brain function as well. You have the stress of managing a chronic disease, pain that our patients experience. There's also things that affect particularly mental health. So have absolutely physical, social, and academic limitations. There's stigma involved of having visible disease manifestations such as the butterfly rash, but also invisible stigma in terms of having a disease that's not common and perhaps isn't outwardly apparent with some of the manifestations, but still having limitations and still feeling like they can't really explain this disease, yet they can't function totally normally. There's also similarly a lot of uncertainty. Lupus can flare up even despite our best efforts. And so there's a lot of concern about from the adolescents themselves, is my disease going to flare? They are often very aware that there is not a cure. And then there's long-term uncertainty, like what does this mean for my future? Can I have kids? These are adolescent females for the most part. So these are the things that they're thinking about even when they're 13 or 14. Other things that can contribute are the parent and caregiver well-being, social determinants of health, and genetics and epigenetics. So one thing that I wanted to sort of highlight, which is an emerging area in pediatric rheumatology, but also in general pediatrics, as I'm sure you're aware already, are things like emotional trauma or adverse childhood events. So these are traumatic experiences that happen in childhood. And very importantly, they can be associated with epigenetic changes. So changes to the structure of the DNA, not the DNA coding sequence itself, but the way that the DNA is stored. And these can have implications for expression, gene expression, and also for chronic inflammatory disease. So in case you're not familiar with ACEs, there's a CDC Kaiser ACEs framework that you can see here. In the center, you have conventional ACEs. These are things like physical abuse, sexual abuse, neglect, household dysfunction. But it's also important to recognize that there's sort of an expanded set of ACEs, community level ACEs, that involve community violence, bullying, and neighborhood safety, racism, and things, experiences such as living in foster care. What's very interesting, though, is some literature that's come out in the adult literature. So this is from the Nurses' Health Study, which is a prospective cohort study of women, nurses, who volunteered and gave their data over years and years of follow-up. So what's interesting is that they reported their ACEs experience, so particularly here, childhood physical and emotional abuse. And over time, some of them developed rheumatic disease. Some of them developed lupus. And what they found was that those with a history of abuse had an increased incidence, so an increased risk of developing lupus over time, over 2.5 times the risk. So that was very interesting. When we looked at our cohort at Sick Kids, what we found is that 34% of our patients had a traumatic event history. Now, this was a more strict definition of traumatic events than, let's say, the expanded ACEs. And 20% had clinically significant PTSD symptoms, and these are associated with depression and anxiety symptoms as well. So what we wanted to do was to look back and see, let's look at this a little more. That looks like it might be something of interest. So we found we looked at a retrospective cohort within our clinic of lupus patients, over 200 patients. Now, the limitation here is that this is retrospective. So you're only going to see in the chart what is actually discussed in a medical encounter. So that's not going to encompass all of those ACEs I just talked about. And then also B, what makes it into the medical chart, right? Because as we know, we don't necessarily put everything we discuss into the medical chart. Even then, with those limitations, we found that 41% of the population had at least one ACE categorized. And you can see the most common ACE that we found was separated or divorced parents, followed by bullying and parental mental illness. But you can imagine if we did this prospectively, we'd find probably many more ACEs. And in fact, I'm not showing you this data. We have since done that, and that number raises to 76% of our population. And not only that, about 20% have more than 4 ACEs, which is definitely in the literature correlated with bad outcomes. But back to this retrospective study, even with this limitation, we found that the presence of ACEs in this 41% was associated with 5 times the odd of depressions and anxiety as recorded in the chart, which again, it's only what makes it into the chart. In a subset of those patients, though, we also had executive function data, and we found that ACEs were associated with executive function, both self-reported and performance-based. So this is something that we're looking at more. In addition, we found that 55% of the ACEs were actually able to be identified as occurring before the lupus diagnosis. So this is thinking about that temporality. And what we found is that if you had an ACE before your diagnosis, you had a higher risk of accumulating organ damage. So this is something that's emerging that I wanted to bring your attention to, because this is very important for thinking about both our inflammatory diseases, but also our chronic diseases and how social determinants of health are interfacing with our chronic diseases, mental health, and even inflammation. So now I'll talk a little bit about what we know about the impact of neuropsychiatric conditions on outcomes. This is a bit of a short section because we have not really done a lot of studies, especially on long-term outcomes, but I'll share a little bit about the work that has been done. So we know for mental health, in terms of depression and anxiety, these can affect different types of outcomes for our patients. So the impact on disease flares and subsequently damage, also disease control as it relates to medication adherence, healthcare utilization as well, transition to adult care, education attainment, and later work productivity and overall quality of life. So just to share a few studies that we've been able to do. So looking at a cohort representing different populations across the US within this Optum Insight database, which is basically a private insurance database across different parts of the US. We were able to look at a cohort of 650 youth with lupus, which that's a big number for lupus, just to say, because our disease is not that common. What we found is that when we looked at healthcare utilization, specifically medical visits, so visits that were coded with diagnoses not for psychiatry codes, but for medical codes, we found that if they had a diagnosis of a psychiatric disorder, particularly depression and anxiety, they had an increased use of ambulatory, emergency, and inpatient services. So on this graph here, you can see broken up by those different contexts. We have on the light bars, those with a psychiatric diagnosis before their lupus diagnosis. And we wanted to characterize this because many patients come into lupus with already a psychiatric diagnosis, which may or may not be part of their lupus. And then in the darker blue bars, those with a new psychiatric diagnosis after the lupus diagnosis, compared to the green with no psychiatric diagnosis. So you can see the blue bars generally are higher than the green bars across all contexts in terms of their mean visits, which is shown on the y-axis. In a similar cohort within the same database, we wanted to look at medication adherence. So I mentioned in the case that, the patient was on hydroxychloroquine. Pretty much all of our patients with lupus are prescribed hydroxychloroquine. This is a medication that is an anti-inflammatory, but it's a milder anti-inflammatory. So it basically helps with all different types of manifestations of lupus. It's relatively well tolerated, so it's something that we feel comfortable prescribing very widely. So this is a good measure for medication adherence because we're able to see on the y-axis, their medication possession ratio. How much are they actually getting these prescriptions filled for the hydroxychloroquine? So again, this is broken up by if you don't have a psychiatric diagnosis in the green versus if you do have a psychiatric diagnosis in the light blue, but you haven't received therapy. And if you also have a psychiatric diagnosis, but you do have therapy, that's the dark blue bars. So what do you see here? Well, first of all, you notice that the medication possession ratio isn't that great. We're hovering around like 60%, which I think is actually pretty true. You know, we're asking these adolescents to take a bunch of medications. It's very difficult for them to take a daily medication. So that was a little sobering. So you see with no psychiatric diagnosis, we're hovering just below 60%. What's interesting though, is if you see depression, anxiety with no therapy in the light blue, it's also kind of around 60%. But notice if they receive therapy, look at how the adherence goes up. So we found that this was statistically significant and an indicator that, you know, if we could address mental health issues in this population, we really might be able to move the needle in terms of medication adherence and disease control and improve outcomes. So we don't have long-term data, but we do have cohorts of adults who had childhood onset disease, and we were able to compare to adult onset disease. So this is data from a lupus outcome study, which is a prospective cohort based in California. There was 546 adults. About 20% of them had childhood onset lupus, 115. So in the white squares, we have childhood onset lupus. In the black circles, you have adult onset lupus, and you have depression prevalence on the y-axis. And so if you do unadjusted analyses, the adult onset people look like they have more depression risk. But once you adjust for things like disease activity and other factors that, you know, you have to think about with adults in terms of smoking history and all of that kind of thing, it turns out that the childhood onset lupus group had a higher depression risk, both for one episode of major depression, but even higher for persistent major depressive symptoms for recurrence. And so one thing that made us think about is, you know, this whole teen brain under construction, like after you adjust for all of those other things, is there something about childhood onset disease that is influencing or heightening your risk for major depression? Also, within that cohort, we were able to look at depression relationship to education outcomes. And what we found is that there was a dose-dependent relationship between those who their education level and their depression level. So basically, those who had the lowest education level, did not complete high school, had the highest odds ratio for having depression at 2.5. And this was accentuated in the childhood onset group. So you can see the white squares for childhood onset basically have a higher depression prevalence across educational levels. We can't tell the directionality from this in terms of, you know, is it less education leading to more depression risk, or is it more depression risk leading to less education? But the association is definitely there and decently strong. Just a little bit on cognitive dysfunction. Much less has been researched in this space. There's actually only one study that really looks at outcomes over time. This is from my institution looking at data all the way back to 1985. So, you know, back then they were really only characterizing for the purposes of, you know, clinical documentation, those who had severe cognitive dysfunction. So in your face, really impaired memory, attention, executive function. When we see this in clinic, this is really patients who, if you ask them a question, a simple question, what do you like better, pizza or fries? You can see the wheels turning. These are 16-year-olds, should be quick answer, but they actually might take a full 60 seconds to answer that question. So this is absolutely something that we see, but this is just to give you an example of severe cognitive dysfunction. So what they found was when they looked at those, everybody had severe cognitive dysfunction in this cohort, but some of them also had psychosis. One thing to point out is that the median time to diagnosis, like it was pretty quick if you had psychosis, like those, you know, it's pretty obvious if you're really having hallucinations, and we see both visual and auditory hallucinations. But if you have cognitive dysfunction only, it can take a little while for things to get diagnosed. And I think that, you know, again, this gets back to trying to attribute it to things. Is it really due to lupus, or are there other things going on? So when they looked at outcomes, they had 53 of the patients. When they looked at who responded, about 82% responded to different immunosuppressants. 63% went into remission, but really it took a long time, a median of 71 weeks. there was a 20% relapse over a follow-up time of almost 2 years. 50% had new organ damage developing even despite immunosuppressants. And really of note, 15% had residual cognitive dysfunction. So it's not so great, right? Like this is a real problem. And these are kids who have, known obvious severe cognitive dysfunction, but certainly doesn't capture everybody who has that manifestation. So I feel like I'm painting a grim picture here of neuropsychiatric lupus and trying to understand and optimize brain health, but there are opportunities. So I am optimistic. One of the things that's been really helpful to try to tackle this very difficult area is collaboration. So we have CARA, which is the Childhood Arthritis and Rheumatology Research Alliance. This is a research network of pediatric rheumatologists, mostly across North America. And most of us are actually part of CARA in some way, over 95%. It involves health and research professionals, but also patients and caregivers, which is very important for a lot of driving of our work. In particular, I've been very involved in the mental health work group, the neuropsychiatric lupus work group, and the lupus committee. And I've put here my co-leaders for the mental health working group. One thing I want to point out is that, for you trainees that are just starting out, if there are research alliances or groups that you can get involved in, it's really, really helpful, especially if you have an interest, an idea. Maybe that's not really established yet. When I started doing this work in mental health work group wasn't a thing. It was not something that was really going on within CARA. But with, the help of a senior leader who said, you could just start the work group. That's what I had the opportunity to do. So we were able to found the work group in 2015, and we've grown it, and we've really been able to do some great work together. And that's what I'll talk about mostly for the rest of the talk. So one of the first projects that we did was to really focus on mental health, like what's happening in pediatric rheumatology. We did a provider survey study of the US and Canada, asking rheumatologists to give their input on how we're doing with addressing mental health. And we also were able to capture the perspectives of behavioral health providers. Most of these people were social workers. Out of the 42, we had about 8 psychologists, so much less so. And what we found was that we weren't really doing a great job at symptom identification. This was for depression and anxiety mainly, but overwhelming majority, 85% of clinicians, of rheumatologists, were in support of routine screening. However, only 2% of the reporting sites had any routine screening going on. So this is back in 2015. Many were interested in being trained to evaluate mental health. But a notable issue was, okay, even if we are able to detect the problem, how can we adequately connect to services? That was thought to be a problem. And then also, even once we refer, how do we follow up and make sure that, the appropriate care is happening? In addition, the social workers and psychologists were a little bit more specific. They said, we really need interventions, targeting anxiety and depression, targeting illness-related coping, also for caregivers, mental health support for transition to care, and peer support programs. So this is something that was not really readily available, but if they had a wish list, this is what they would want to really help this population. But notably, when we approached all sites within CARA, which at the time was 100 sites, only 49% even really had an affiliated social worker or psychologist. So this was really daunting and kind of an uphill battle. At the same time, we thought, okay, let's develop a little bit of a strategy for how to improve mental health care for the patients, both through research and eventually through care. So what we did was we did a literature review in terms of what are the domains that we would even be trying to tackle. We came up with 33 research topics within these 5 domains. So how is mental health related to the actual disease? What's the effect of mental health on outcomes? How do we promote mental health awareness and education, both for patients, caregivers, and clinicians? how do we identify the problem better? How would we implement mental health screening? What goes into that? And how do we address mental health problems once we find them? So these are the 5 broad domains. And we asked our mental health working group, which again, like we started in 2015 and there were maybe, I think, 18 of us. We had grown to like 65. So we asked people, can you rate these topics for importance, feasibility, and actionability? So how important are they? How feasible is it to study? And then when you get results, how much can we take action on things? So everything was important, of course, and we're a little biased because we're asking the mental health work group, but burden in relationship to disease and effect on mental health outcomes was thought to be immediately more important. But the most feasible and actionable was, let's see if we can do mental health screen, because if we're able to do that and identify the problems, we're also able to characterize the mental health issues better and do some research. So we were able to move forward with a multi-center study looking at utility and acceptability of depression and anxiety screening in young adults with lupus. And it was found to be feasible, acceptable, but also needed and desired by this population, which was really important to establish. Like, you can screen for mental health symptoms and disorders, but if the patients aren't really willing to partake in it, it's only going to go so far. So that was really encouraging. Since then, people have really been able to do quality improvement work and implementation work at their sites. I just have a smattering of some papers here recently, but there's many more. And we're very pleased that people are taking the work of the mental health group and able to disseminate at their sites and work with their institutions to try to implement things like depression and anxiety screening. So the first paper here is my fellow was able to implement depression and anxiety screening using quality improvement techniques. The second paper comes out of Nationwide Children's, Columbus, Ohio. They started off with a QI project in mental health screening and since have been able to develop automation integrated into Epic to be able to sustain the screening, because there's a lot of like workflow considerations that need to go in here. And then the third paper is from a group at Vanderbilt. They also were able to increase the screening rates and also maintain them over time. So we're very, encouraged by the fact that people are able to do this. Another project and accomplishment, which is just recent, sort of hot off the press, well, I guess it's May now, May 2 months ago, is that we were able to develop what we call mental health guidance statements for use by the clinicians in pediatric rheumatology. So in order to do this, you'll see 11 statements here that were endorsed by the American College of Rheumatology. So this is, coming from the body of rheumatology. They're endorsing this and saying this is important. We were able to grade a level of evidence for each of these statements that were developed by the task force, which included multidisciplinary people that you see up top on the right. And the evidence level, range some 1s, which are the highest level, mostly 2s, some 3s. Of note, there were like 36 statements that had lower evidence levels, but also we wanted to look at level of consensus. So we asked the CARA membership, would you agree that this statement for care practice would be valuable? So you can see the first statement is that screening for anxiety, depression, and suicidal ideation should occur annually at a minimum for individuals aged 12 years and up. That was a level of grade evidence 1 with a level of consensus at 84%. So I won't read through all of the statements, but this was a major accomplishment to sort of get this on the map in terms of the practice considerations for rheumatologists. Now, you could argue, as many of the rheumatologists might argue, well, but we're not primary care. Like, why should we be doing this? The reality is that many of our patients see us the most common, more so than the primary care providers. So what we've developed is education modules and workshops for our pediatric rheumatologists to learn about mental health screening, the importance, approaches to doing it, and how do you work and develop multidisciplinary teams to be able to accomplish it. So I just showcased 2 of the workshops that we've done in the past, and there are workshops ongoing. At Sick Kids, we've been able to implement automated mental health screening with integrated social work support. This is a hospital-wide initiative as part of the mental health strategy. It's done through an app called Voxy, screening for depression and anxiety using the PHQ-9 and GAD-7 for children 12 years of age and older. And screening is done up to every 30 days. Notably, the scores are automatically implemented into the Epic EMR. You can see here a little bit of a snapshot of how this might look. So when a patient comes in, they complete the screening through the Voxy app. When you open your Epic screen, you can see the scores as depicted here, and they're color-coded to let you know the severity of the score. And of note, you can see in the triangle with the exclamation mark, that is our suicidality indicator. And all of our clinicians are trained for acute suicidal ideation assessment. This was launched in December 2023, requiring a lot of communication and coordination with our social work department. Screening rates 70% could be improved, but definitely a start. Well, one thing to note for mental health screening in lupus, it's really a multidisciplinary effort, right? So this is not a general pediatric population. We have to consider, could there be neuropsychiatric lupus? Could there be other neurologic features? So we need to work closely with a bunch of different specialties. We work very closely with our adolescent medicine colleagues, and so they provide things like psychoeducation and also mental health and social worker referrals if needed in addition. One thing I wanted to point out here, though, is look at the breadth of things that they can help with in this chronic disease population. This is why we work very closely with them. And prior to the mental health screening, they were identifying a lot of our mood issues. Now that we have the screening, we're identifying them up front, but we're still working closely with them on a breadth of other problems that can come and coincide with mental health problems. For our neuropsychologists, this has always been very tricky and certainly is not optimized at our institution. But one thing that I've been able to do is work very closely with neuropsychologists in our institution. You'll see them listed on the right. And neuropsychologic testing can take quite a long time. And it can be very burdensome for patients. So one of the things that we've done is to develop ways to have some virtual component, like a virtual intake, and then have an assessment abbreviated in person during the day. But of note, this type of care requires a lot of real-time communication because we're actually trying to make medical decisions about whether they have neuropsychiatric lupus and whether they need immunosuppressant treatment, specifically related to neuropsychiatric lupus. The other thing that I wanted to point out is that we've been working very closely with patients and families to understand their needs and how they feel about mental health. We were able to do what we call a patient-engaged study, where we have patient partner involvement from the get-go, from the project development through this. In this case, it was a survey, through sending out the survey. And we asked patients and their caregivers, who are you most comfortable seeking mental health care from? And you'll notice at the top, there's sort of more your classical mental health providers. And at the bottom, you have a rheumatologist and a primary care provider. In the blue are the parents, so they're just more comfortable than the kids in the green in general. But they're most comfortable with the rheumatology and the primary care provider, but really most comfortable with the rheumatologist. And this is a quote from one of our qualitative studies. We actually consider the rheumatologist the primary caregiver. And this coincides with the qualitative comments from that study. Mental health providers, one of the barriers is that mental health providers don't really understand the disease. So unless they're really integrated with the rheumatologists and they understand the population, that can be a real barrier, in addition to cost and time. So one of the other things that we've been working on in the mental health work group is how to make a better intervention. Sure, you can refer to community psychologist, community counselor, community social worker. If they don't understand the disease, that may actually be counterproductive. So working with a colleague at MSU, Dr. Cunningham, she had developed an intervention for chronic abdominal pain. She adapted it to lupus and called it TEACH, Treatment and Education Approach for Childhood-Onset Lupus, targeting particularly depression, fatigue, and pain, but all together in a 6-week program that was developed with patients and parents and also adapted for Zoom delivery, realizing that accessibility is a real problem for our patients. Conducting a multi-site randomized controlled trial of TEACH versus sort of our usual way of doing things. In a smaller study, we found that there was a lot of retention, a little bit of recruitment issues getting people on board, but once they were on board, they really stuck with it. And we found that TEACH improved depression, anxiety, and fatigue. People really appreciated this being integrated in terms of finding out about this intervention at their rheumatology site, then being, ushered into this intervention, they felt like it was just part of their care. So we were able to get money to conduct a larger effectiveness implementation RCT across different sites. And so we're really excited to be conducting that study now. So for the last few minutes of the talk, I wanted to talk about, where do I see things going? We've been able to identify depression and anxiety. Great. We've been able to work on thinking about how to intervene, but, this is a population where the phenotype is maybe not the same as a general pediatric patient without a chronic disease, without potential for neuropsychiatric lupus. So how do we go beyond phenotype into endotype? How do we get a little bit better at understanding what's due to lupus and what's not? One of the ways to do this is to look at multiple different types of biomarkers. So I just wanted to highlight some of the work that's ongoing in my lab at Sick Kids. So we're doing a longitudinal study of patients with children with lupus, and we're comparing to controls, age and sex match over 3 time points. And so we do have some cross-sectional data, which I'll share with you. So we have this cohort of lupus patients. Again, 60 looks small, but it's actually kind of big for our pediatric lupus. This is, again, our Sick Kids cohort, and we have matched controls. Basically, as you would expect, it's mostly female adolescents. For lupus, they're relatively early in their disease, about a year. They have relatively low disease activity, although about 43% have active disease. About 40% have a kidney involvement, lupus nephritis, but very notably, we were only really able to recruit 2 patients out of 60 with neuropsych lupus, which may be viewed as a limitation, but interestingly, we have some interesting findings. So I wanted to introduce you to these brain injury markers. You might have heard of these in the context of Alzheimer's, dementia, Parkinson's. These are things like neurofilament light, also used in multiple sclerosis, GFAP and tau. These are things that indicate brain injury. And we wanted to look at how do these brain injury markers look in lupus versus controls. So our preliminary data shows that these brain injury markers, particularly GFAP and tau, are higher in our lupus patients compared to controls. And they correlate with worse disease severity, disease activity, higher organ damage levels, higher interferon levels, which is one of the major cytokines involved in lupus pathology, higher current steroid dose, but not the cumulative steroid. So really tends to suggest disease activity and also worse executive function. And notably, most of these patients, the majority do not have lupus, neuropsychiatric lupus diagnosis. So are we missing something clinically? Is there something going on that we're not picking up? So this kind of work is really important. But another biomarker that we're looking at is brain MRI, advanced brain MRI. So there's something called functional brain MRI where you can look at resting state networks and understand, the connections within the brain. This is something that my postdoc fellow is, who's a neuroimaging scientist, is really helping with. And just to point out that we're finding that there's decreased connectivity between regions compared to controls across attention networks and sensory motor networks. It's accentuated. If you look at those with active disease, you can see all of those blue dots, and those blue lines are basically showing lower connectivity in lupus versus controls. And we also see that if we just isolate the group of lupus nephritis. And we found that, interestingly, increased functional capacity is associated with better cognitive function. So this is suggesting that maybe there's some compensation happening. What's interesting is that if we look at cognitive function in lupus versus the controls, it's actually pretty similar, except for processing speed. So this suggests that there could be a deficit that's happening with the processing speed, but they're able to compensate for most other things. So this is just the tip of the iceberg. This is new work that I wanted to share with you guys. And also to point out that we have a collaboration with our very own, your very own, Dr. Cassie Torak, who studies craniofacial lunar scleroderma, which is another disease, which I won't get into. But you can basically see that this is one of our rheumatology diseases that can cause disfigurement and lesions on the skin, but also the underlying face. So you can see in this patient that they have abnormalities in terms of the way the forehead and the left side of their face is formed. And in the MRI, you can see that there's also underlying brain parenchymal disease. When we looked at 40 children in the registry here, we found that not only were there brain volume changes on the side, on the same side as the lesion, but also on the other side. So we're thinking that there might be diffuse brain changes, and these have been correlated also to school function and quality of life. So more to come as we look not only in lupus, but other autoimmune disease. So to wrap up, thinking about, how do we optimize brain health? Well, I think that not just phenotype screening, but also endotype screening, things like incorporating serum markers, brain imaging, and later on genetics will help us understand, in addition to things like external factors, social determinants of health. And that can hopefully get us towards better understanding how to identify things early, how to provide appropriate therapies that are tailored to the patient, integrated into care in a routine way, in a timely way, and in an equitable and accessible way. So in summary, I've told you that neuropsychiatric conditions are common, but also challenging in these children with lupus. We need better studies examining various underlying mechanisms to develop better diagnostic tools and targeted treatment. Secondly, addressing brain and mental health challenges in lupus are critical to improve outcome. You could, though, also think about other chronic diseases. So I've told you a lot about lupus, but I also challenge you to think about how might this be applicable to perhaps your disease of interest or your population of interest, because multidisciplinary expertise has been very valuable to approaching this problem. And then also that, integrated care has become very apparent to be important for how to intervene. Similarly, multi-stakeholder partnerships have been very important to tackling this. So this is not just researchers and clinicians, but also patients, families, and patient organizations. So with that, I will stop. I have a lot of people to thank, patients and families, my lab, other people at Sick Kids, CARA, and all the organizations that have funded the research. Thank you very much.